Good evening, everyone. Thank you for attending AACP's webinar with Dr. Bahar Esmaili, presenting Mysteries of the Mandible from Nose to Toes. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 45 minutes, followed by a 15-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. Dr. Esmaili is owner of RhinoVive LLC, and the AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 5 to 7 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. I would like to mention a couple of upcoming events for the AACP. Our next complimentary webinar will be May 10th with Dr. Tony Bolamperti, presenting treatment of snoring with the 9.3 micron CO2 sleep. Also, for education, camaraderie, and the latest in craniofacial pain, be sure to visit aacfp.org to register for this year's annual symposium in San Antonio, Texas, August 11th through 12th. I would like to introduce our speaker tonight, Dr. Bahar Esmaili. Dr. Esmaili grew up in Iran and immigrated to the United States when she was 20 years old to pursue her dream of becoming a doctor. Since graduating with honors from the University of Colorado School of Dental Medicine in 2009, she has completed numerous advanced continuing education courses in the fields of craniofacial pain, TMJ disorder, and airway dentistry, and currently focuses her clinical practice on the connection between oral and the whole body health. More than just a practitioner, she is a passionate educator and goes out of her way to help her patients understand the why behind the what of their issues. She is a certified personal trainer, specializing in posture correction, and is passionate about the interconnectedness of the human body. In light of her profound realization that straight teeth cannot fit on a crooked body, she is on a mission to enlighten practitioners of their ability to impact compensatory mechanisms that ultimately lead to the breakdown of our bodies and our health. And most recently, Dr. Esmaili has joined AACP's Education Committee, and we're super excited to have her involved and really excited for her presentation tonight. So with that, Dr. Esmaili, I will hand it over to you.
Well, thank you, Shaylene, for the amazing introduction, and welcome everybody to tonight's presentation. I'm looking forward to connecting and learning with all of you. Mysteries of the mandible. How I actually came about to pick this topic is going back to the story of how I became very interested in the whole concept of mandible, temporomandible joint, and beyond the one tooth and arches. So that's kind of the story of how I ended up being here and telling you guys all about my background from physical medicine, being a personal trainer, and then being a dentist. I'd like to make a quick disclaimer before we move on, that the information I'm about to present for you guys tonight is just for information and educational entertainment purpose, and it should not be used exclusively for clinical decision makings. And I have absolutely no conflict of interest with the products or website I'll be presenting here. I want to just leave this picture over here for you guys for a few minutes. And I want you to know that what about information that I'm presenting here, most of it I learned from a lot of our great leaders, my mentors over the last few years. And I have sorted out a lot of information that didn't make sense to me, and I'm presented just and the best of what actually did make sense in my clinical practice. And I'm hoping that you guys can take away something that it would add to your armamentarium and help you. And maybe I can tell you something that can give you a new perspective in viewing the TMJ. And I learned very quickly after going through and reviewing and learning things that there are a lot of opinions in our field, and they do not reflect facts. So I hope that I can extrapolate and present a few facts in here. First and foremost, I learned very quickly that body is a very sophisticated machine. It is perfectly capable of healing itself if we can help decompensate it instead of treating it. Because treatment is focused on one or two things in one area in isolation. But when we're focusing on decompensating, it quickly changes our focus to really diagnosing and understanding what the body does, how it works, and why it's not working properly. In a reductionistic way of looking at the body, we focus on symptoms, but looking at the body as a whole, which is a premise of the holistic dentistry, holistic medicine, it's way easier to treat the body because symptoms will never confuse and distract the clinician. And this is my saying of healthy and highly medicated, two different things. We can keep someone maintained in a disease stage, but creating health, that requires a lot broader spectrum and view. And we, the dentists, are actually architects. Our focus in dental school and our dental trainings in mainstream dentistry was just about the single tooth or the arches or inter-arch relationship at the max. But I understand as a dentist, my role is to be a neurologist, an architect of head, neck, and the entire body. And in collaboration with the physical medicine, we have the ownership of the entire health of the body. That's a huge responsibility for the dentist. And first and foremost, my conclusion, straight teeth cannot function on crooked bodies and misaligned bodies and crooked skulls. We're going to get to some of that today. An autonomic nervous system wins. It's all about survival. Everything we do in life, the way we stand, the way we move, the way we react to the world, how we react and use our senses, it's all about surviving. An autonomic nervous system make that decision for us without us knowing every second. We're all familiar with this. We have differences of opinions in the way we look at things. I could be looking at the mouth. A chiropractor could be looking at the neck. A physical therapist, posturologist, or a MD or a physical medicine. In any area, we could look at the same exact object, have completely different opinions. But at the end of the day, we need to get over that bias. And to be able to do that, we have to unlearn some of what we have learned. When I learned in dental school was how the teeth come together, point of initial contact, guiding the mandible. But when I learned from the other views of the body aspect was, when the body has put the bones in different places, the teeth are malaligned, and that would direct their growth. Completely different viewpoint, but all at the same time true. So that's a good segue for me to introduce TMD as a whole body misalignment. There are a lot of people that think that way, but do we really practice it? These are the challenges that we see. First, there is really no definitive treatment for TMD. It's about differential diagnosis because temporomandible joint is practically the hinge between the skull and the body in propelling, gait motion, sitting, standing, talking, swallowing, all the reflexive modes. And there's absolutely no CPT coding for that. So to restore the homeostasis and bring the body to balance, the focus is to bring the functions back to where it was supposed to be and designed to be. But unfortunately, there's no medical coding that really completely points to that and cover that. And the goal, decompensate, not to treat, but to remove the splinters from how the system is supposed to function so it can optimally function. An autonomic nervous system that doesn't have to be overtaxed and overworking to bring all the functions together. Goal, symmetry, flow, and function. I'm hoping by the end of this tonight, I'm able to bring those three together so we can all have a better, greater appreciation for the TMD as a whole body disorder. So let's talk a little bit about my favorite bone in the body, which is the mandible. In my humble opinion, mandible is not really part of the head. In fact, it's part of the spine. I like to think maybe mandible, from the origin of its development, was meant to be a part of the spine. It's one of the vertebrae, pretty much like the thumb. The thumb is not included as part of the fingers. It's part of the hand, but it's really not one of the fingers. So if you think of the mandible as an extension of the spine, it's just suspended from the neck, shoulder, and the skull. It's really not connected via suture to the skull. And it's swinging like an airplane. Muscles, ligaments, and a bunch of other tissues are making it move and connect to the skull. And at the end of the day, it articulates with the skull only through the dentition. The hard surface of articulation between the mandible and the rest of the skull is only through those 32 teeth, ideally 32 teeth, inter-arch relationship. And it only does that through the maxillary arch, which is the landing pad. So this is how I see the mandible in a nutshell. So let's cover some facts about what controls the movement, position, and at any given point where it goes. First, reflexes, and it does this through muscles and the teeth. What are those reflexes? First and foremost, the most important reflex that our body functions with is breathing. Without the next breath, it doesn't matter what's for lunch. Everything that body does, all the reflexive reflexes are geared to make sure that next breath happens, whatever it takes. Then swallowing, the communication of the bodies to the head is through the tongue function to coming up the teeth together. Swallowing is another reflex that's really controlling where the mandible is. And at the end of the day, balance. We'll get to what that means. Muscles that control the mandible, infrahyoid, suprahyoid, shoulder muscles, neck muscles, masticatory muscles. And one fun fact, there's 136 individual muscles, which is 68 pairs, control the position of the mandible. And at the end of the day, teeth. They help communicate the position of the mandible to the brain via mesenchymal cells directly to the brain with every swallow and every contact via periodontal ligaments that are attached to the bone. And pretty much they have the same mechanoreceptors receptors as every other synovial joint. They communicate where the mandible is and where the body is at any given moment, and pretty much communicating head and body together. And those forces, as I was saying, are directed through the periodontal ligaments to the brain. So when I was doing this presentation the first time, my analogy has always been block, door, building. That's how I see teeth, jaw, body, and the whole system. So I went to Google and I typed in misaligned door frames because I was trying to capture some images that helps me put this presentation visually together. And right at the bottom, the Google robot suggested, oh, you might be looking for some misalignment in the skeleton, or maybe TMJ problems, or maybe, spine issues, or crooked teeth and misaligned mandible. I had to screenshot and share this with you guys that Google robots totally got what it is I'm trying to do. And this is really what it is. Teeth, jaws, head, skull, spine, it's all working together pretty much like a building. Now, many analogies can go off of, but this is the simplest way that I can put it together. So now that we're talking about spine, cervical spine, let's cover that a bit. This is one of the rather older theories out there, quadrant theorem of Casey Guzet, who developed this theory about the position of the mandible in relationship to the upper cervical to be specific C1 and C2. He hypothesized and proved it that movement of the temporomandible joint, although it's hinging off the skull from the TMJ, but it's very closely related and controlled by the position or the odontoid process of C2. For those of you, I'm sure everybody's familiar with, C2 is the only cervical spine or only vertebra in our spine that has a dent or the odontoid process. So the space between the C2 and C1 controls via ligaments and muscles where the mandible goes. So that's the axis of the rotation. He also hypothesized when the mandible moves down, muscles that are attached to those two vertebrae loosen up and the neck decompresses. And when the mandible closes, those muscles tighten. This is a really important concept to keep in mind as I go through the rest of this presentation, which means when the vertical dimension in the mouth or position of the mandible is decreased in relationship to the skull and interarch relationship, that will put tension between C1 and C2. Here's a visualization of that just to prove the point. Here's cervical spine number 1 or axis, and this is C2, atlas, and C2 or axis, and here's the occlusal plane. This is a normal occlusal plane that's in a good relationship with C1 and C2. Now, when the mandible hinges, the hinge of man opening and closing lies right in between those two. So if there is any misalignment of the upper and lower jaw, and the teeth are malaligned, that will lead directly to posture of the neck being disturbed in between cervical 1 and 2, and that leads to neurological complication. This is where majority of the symptoms we deal with as TMD come from. So continuing with the theory of Casey Guzet, here's a normal relationship of the upper cervical to the mandibular occlusal plane, and here's a pathological relationship. So if the plane of occlusion is above the horizontal line that lies between C1 and C2, that correlates to increased freeway space, decreased VDO, and compression of the upper cervicals, and telltale of stories of all the symptoms we see. Here I'm referencing where I got this picture in the article if any of you guys are interested in reading on it. So another fun fact about mandible and occlusion, where I see the occlusion, or I should better say after I learned and studied more about the TMJ, I conclude that the occlusion does not begin between the teeth. In fact, it starts between occiput and atlas. Here's a visual. I'm going to play this video. This is going to show when the occlusion or contact between the teeth are not supported, how it affects the C1, C2. And if the C1 and C2 don't have a good relationship, how it would affect the position of the mandible. It is back and forth. So I'm going to go ahead and play this video. And here's a picture of one of my patients. And the two pictures that are going to be played in this video are about 10 seconds apart. One with an appliance in the right correct position in her mandible, which supports her neck, and one is without. And for those who are interested, those two pictures only are 1 millimeter apart between the maxilla and the mandible. So let's talk about what directs the mandible, because everything I learned about TMJ was directed towards teeth, appliance that we put in between the teeth. But I want to reverse the script and challenge everyone to think, which one came first, teeth or jaws? We all know the answer to that. Teeth are the neurological organs. In fact, they come into the mouth as the kids develop and they start going from reflex modes to developing motor skills and more sophisticated motor skills. The sensation of environment, the three-dimension positioning of the head over the spine, and the entire body and gait motion, locomotor motion, and movements are directed from where the teeth are and how they communicate position of the mandible to the head. So in fact, teeth do come in the mouth, reflecting what's there, not the other way around. So their function is to erupt, to communicate neurological development and follow the neurological development of the body. So if the bones that carry the teeth are not in a good position, if they are not in a good correlation with each other, teeth will not have a chance to come in a better relationship, and they will communicate that information to the brain. Whereas the position of the jaws are mostly reflected by breathing and swallowing and balance, for the most part, are actually part of the development as the kid comes into the world. So the skull and the body misalignment from the minute of birth, pre-birth, and during development directly affect the teeth. So when the bones are not in the right place, when the body's out of alignment, it creates asymmetry. So we know that symmetry is good and asymmetry is not. We all know the answer to that. But why? Let's give you a visual to work with. I love this picture because it's simple to understand. We have two people. It's an animation of a person standing on a board. One is balanced and one is not. So which one do you think is in a homeostasis? And the answer is both. But the one on the right side has to work so much harder to maintain that homeostasis and balance. That's one fact. Secondly, this person does not have that much tolerance to any change that would be put on the system. If somebody comes and just change the board on one side, he has to work so much harder to recapture and maintain that balance. That goes to speaking of a person that is already misaligned from top to bottom, ascending and descending. So this person, if a treatment is done, if an appliance is inserted in their mouth or an orthotic put into the shoe or adjustment done in the neck, the entire system has to reestablish this system, this homeostasis or allostasis, while it doesn't have much to give. No, the difference between patients is what they have for adaptability in this picture, because to keep maintaining life in the lack of homeostasis or asymmetry will take a lot more. And the more they incur changes, treatments with focus on symptoms, the less they have to adapt as they go through life. We know people that make it to be 100 years old, they have one thing in common. They are symmetrical. Their body's nervous system hasn't been taxed. They have much to give by the time they get to this age. So let's start by a common patient. This is somebody that walks into your practice, and I'm seeing a gentleman has gone through orthodontics and wearing the retainers religiously. But let's take a quick look and see, if we were not so focused on the teeth, what else would we see? Here's a view of the mouth. And here's a picture of the CBCT skull and the analysis. I'm going to go ahead and draw some lines, the occlusal plane, as if it was level and balanced. Put the midlines in place and check that out. One maxilla is completely higher than the other. And if you're looking at the person's face, that asymmetry continues. temporalis on one side and ear are completely flattened out. Sternocleidomastoid mastoid hyperactive on the other side. Well, if you think about the teeter-totter that happens, temporalis here is overactive, sternocleidomastoid here overactive, and they work in the opposite of each other. So they're trying to get this maxilla to come down and be balanced for every single swallow. And when we look at the CT scan, the attachment of the sternocleidomastoid and the position of the temporal bone, in all essence, is reflecting it. So let's start deeper. Look at the building. Draw the midlines. Look at the position of the three neurological grounds: ocular, occlusal, and optic, and then neck, shoulder, and hip. Seeing that the body follows that pattern from ankle to the hip, and the shoulders, position of the hands, position of the skull. The pattern continues with the eyes. And I'm hoping at this point that this picture is allowing to see what is the body doing for what it doesn't have to function properly to propel, swallow, and keep its balance. So taking a look at a diagram, here's a misaligned skull and a mandible, the airplane that follows it. We're looking at the one that is in fact supported correctly on both sides, and a neck that is supported correctly over the spine. And the shoulder position changes, mandible position, skull, where it's held against the spine, the entirety of the spine, and the hip and ankle that's below it. Again, I'm referencing the website if you guys are interested to read more about and learn more about this. So when the mandible is up against the crooked skull and the system that's not balanced, every time that the teeth come together, the position of the teeth are going to produce different forces on two different sides, and they're not balanced. And all of that force is going to be translated throughout the skull and throughout the spine and cervical spine, all the way to the tailbone. Now, this is where the dentist really is an important part of the patient's health, because all those forces and all those compressions on the neck, all those compressions on the spine are going to come with some consequences. Function, the autonomics that control the digestion, the temperature, the hormones, all of it would be out of balance. When a dentist is seeing this, they should be seeing directly what the body's nervous system is doing, function is doing, breathing, and all alike. And yes, their sleep is going to be disturbed, their breathing is going to be disturbed, their functions and quality of life. So now that we talk all about the dysfunctions, I'd like to talk about function. This is something that there's not much talked about because we always see disease. But where would the mandible really want to be if things were ideal? Here's a picture of myself when I was receiving some treatment with an oral appliance that was aligning my mandible. Picture on the left and picture on the right are about a 1 day apart. Position of the ears hasn't changed much, but I'm hoping everybody can see the amount of strain here, especially on one side of the face versus the other. And if you're looking at the midline, the position of, again, temporal bone or the temporalis and sternocleidomastoid, nose to the chin, and the masseter activity, it all relaxes just by changing the position of the maxilla to the mandible by a few millimeters in the right direction, in the right place. But how many of us actually look at the eyes? By changing the position of the mandible, the strain in the left eye, or pardon me, the right eye actually went away. So we know there's neurology involved in both sides, and neurology that actually is controlling all those movements and the functions. 92% of our cranial nerves are passing somewhere in between the sphenoid that holds the eye and temporal bone that holds the temporomandible joint. And where the mandible goes and lands on the maxillary teeth is going to affect this. So here we're talking about mandible, skull, and the entire spine. So this one came from the Portland TMJ clinic. I do know the author very well, and I have permission from him to share this that was mentioned in one of the articles. So it's talking about the skull changes inclination to establish itself over the hip. So in essence, where the mandible goes, the body mass goes, and the skull has to follow the neck. So it's all about reestablishing where the teeth come together as a landing pad, and then head knows where to line itself over the hip. So when the vertical dimensions collapse, the skull and the cervical spine is compromised. We already covered that. So the spinal column underneath of that will have to shorten its length to accommodate the same amount of vertebrae now in a shorter space. And that's inducing cervical lumbar lordosis, kyphosis, overcurvature, undercurvature, military neck, forward head postures, and all the like. And when the head is in a forward posture, it will affect the expansion position of the rib cage and posterior mediastinum, which is the space behind the lungs, how the patient can breathe diaphragmatically or not able to diaphragmatically breathe. And this is all coming together. And I'm going to go ahead and play this video here that shows if the mandible would in fact be in a better place, how it affects the curvature in the cervical and the entire spine. So let's talk about microocclusion, which is what most dentists are familiar with and is most taught in dental school, versus macroocclusion. I see the microocclusion as locks in a door. That's teeth. When we're trying to get the locks in the door in the right place, when you have a stock door and a lock that doesn't work, if we only see that view, all we see is the lock. I want to challenge everyone to put the loops down and look at the macroocclusion, which in fact is the door frame that holds the door and also the building that holds the entire door frame. I'm sure a lot of us are familiar when we see the crack on the side of the door, we know this is not a door frame problem. This is an entire building problem. Let's look at the teeth. A lot of examples of the patients, because that's what we're most familiar with. Laying on the midline, occlusal plane, mandible is shifted to the left side, and there's a crossbite. Maxilla is on the left side, internally rotated. Everything is shifted to the right side and is underdeveloped on the left side and shifted to the right. So let's take a look at the actual face. The occlusion that belongs to Mr. O'Neill. So Shaq is holding a straight blade in between his teeth, following the occlusal plane and the ocular lines. When we look at his CBCT, that's where I see the door frame and the hinges that hold the teeth come together. And looking at the midline, the head is shifted to the right side, and eyes are also higher on the right side, and mandible shifted to the same side. However, the maxilla on the left side is restricting the movement of the mandible in a crossbite. We're starting seeing what is the door frame doing to the hinges and to the whole function. And let's take a look at the whole building and how Shaq actually stands up and holds his posture. He told me his entire career, he was a right-handed athlete. And we actually can see that. If you look at his midline, the entire head and the body is shifted to the right side. The torso is more forward on the left side, and the hip is back. Position of the shoulders, position of the ankles and the knee, and where the hands are tell us everything we need to know. So after we aligned majority of this, the system, and we're able to get into the sphenoid and move in the occiput, the before and after are just 2 months apart. This is 2 months of treatment, planning to bring the mandible in a much better optimal position for what we needed to accomplish. And they quickly responded within weeks, going from misaligned mandible, misaligned eyes, to a completely level eyes and completely level mandible. Effortless. The difference between these two is not just static, it's not just positioning mandible and the teeth in a better place, but it's all about what the autonomic nervous system was doing when he was here and unable to control majority of function symptoms, locomotors, and all of those alike. So the eyes are more in a better position and everything else that follow it. So I'm going to go ahead and play a video. I'm going to go ahead and tell you what you guys are about to see is some snapshots of the treatments that was performed. The testing, reflex testing I'm performing here is something that Dr. Stephen Olmos taught me years back. And I'm performing that test where he failed the test, and it was showing that mandible, the skull, and the entire spine was in an autonomically sympathetic nervous system. It was failing the test. And when the appropriate treatment was done with an SOT chiropractor who's sharing the picture with me and Shaq here, what the response was when I was able to insert oral appliances in his mouth, and we're seeing how quickly the body, even a 7'4" human being, respond to a treatment when it's done the correct timing. Just one swallow is all it takes.
I'm not going to force it. I'm just seeing how
From an injury?
Away. So it stops about 100 degrees.
That's the problem. So the recumbent position is because that's the only way he can continue on with the, breathing.
Yeah.
Because you're using gravity to breathe.
His fascia, like both shoulders are locked in place, so it's not opening. I'm just going to palpate your neck. See how this is coming?
Nice. Still.
You should call your series Fix and Check.
Fix and check.
Yep.
by Dr. Tim and Dr. Bahar.
You should start off to say, tell everybody what my problem is, and then tell who you are and tell who you are.
I love that.
You're the best. We really appreciate that. Oh my gosh. Tim, look. Nothing in between his teeth. This was complete fail in the first here. Okay, nice. Perfect. Good. Nothing.
We all established is slightly taller than me. So the trajectory of the mandible, now that we know more about the mandible, let's talk about how it actually functions. It's pretty much like an airplane. It moves in roll, pitch, and yaw in 3 dimensions. So when we open the mandible, within the first 25 millimeters, pretty much like an airplane flying at 35,000 feet. When the mandible comes closer to closure, last 25 millimeter, it's kind of close to landing. So what controls the mandible in open position are basically relationship of the condyles to the fossa, neck, occipital joint to be specific, C1 and C2, which we saw in Casey Gouzet's quadrant theory. Airway patency is the most important. Mandible follows the tongue and the hyoid bone. Where the mandible goes, the tongue goes, and it supports the airway or impede. So the reflexes that control the airway completely direct where the mandible goes when we are opening. Matter of fact, our mandibles go into translation and rotation in order to move the mandible and the tongue out of the airway because we are bipedal animals. Dogs don't go through translation of their mandible. They only have rotation because they don't have to get their tongue and the airway and the mandible out of the way because they're on 4s, but we are on 2s. And the body mass balance, because mandible follows the body mass and it will direct where the body goes underneath the head to support it. The occiput and temporal bone hugely affected where the mandible is positioned in the path of closure. So the temporal bone in the patient that I showed on one side was completely internally rotated and impinging on the condyles because the hip on that same side is probably misaligned. And that would affect where the temporal bone goes. It has no bearing on the teeth. However, near closure, mandible, like an airplane, is looking for its landing pad, which is the maxilla. So the teeth will have a direct effect on where it lands. So if the maxilla, which is our landing pad, is uneven, because the skull is uneven, that would direct where the mandible goes, and the teeth will communicate that to the brain as the body is not aligned. And the cranial alignment, which I just explained, is directly affecting that. So think about the maxilla and how the body is dealing with getting it level as the landing pad. Airplane cannot land on, or helicopter can land on a slope. It has to land on a landing pad that's level. So what the body does will artificially level the maxilla by employing the muscles on the opposite side, like sternocleidomastoid and temporalis, to create that. And over time, that will affect the cranial alignment. And from then on, it becomes a telltale story of where the body falls apart. So if you've seen this occlusions before, this is how I see the landing. And I talked to a lot of pilots, and it appears that this roll is not where the airplanes should be landing. The pitch is an ideal. And definitely this is a crash. We see when a tooth fails. It's not a tooth failure. It's not an arch failure. It's a whole body failure. So some facts that I've compiled into a rule of 3B that I wrote, that every breath needs brain and balance. Let me explain. So there's 3 triangles that are stacked on top of each other: head, torso, and pelvis. The neurological balance between these 3 triangles are super important for an autonomic function. When they are out of alignment, these are the symptoms that would follow. So the first reflex and the first need for the body in any position, especially in erect posture and locomotor function, is breathing, and then balance, and then brain. And let me tell you what they all mean. We already established the most basic reflex is breathing. Whatever it takes, body will do, shift, switch, turn you into a pretzel to make sure that breath comes in. And the next is spinal fluid that goes around the brain and the spinal cord. The cranial bones, the maxilla, and the eyes need to be level for every swallow, which is roughly about 500 to 700 times a day. And then overall, the brain has to stay over the center of gravity. So if you're seeing a patient with a forward head posture, the head is in a completely different position, compromised position over the cervical spine. That cannot be corrected. if the body's balance and breathing are compromised. So to decompensate, this is the order I see it. What's impeding the breathing, what's impeding the balance before we put in the head over the cervical spine. Which actually makes me think, there are a lot of saying that resonate with someone that has a sound mind is having a good head over the shoulder. That actually kind of makes sense. So the way I see the body is when we stand up, pretty much we have a closed circuit between the teeth that come together and the neurological ground between the feet and the ground. So kind of like if there's a twist in the spine and the posture, I see it like the twist in the coordinaphone. So you can move the twist up and down, move it in the middle, but until we remove one of the attachment points of that cord and detangle it and reattach it, we won't be able to address the whole thing. Pretty much like what I do with every patient. Picture on the left, this is actually a patient that I treated in an integrative with postural specialists, chiropractors, PTs, and oral myofunctional therapists to get the body into the alignment from the left picture to the right. There's about 16 months between those two pictures. When you're looking at that, I do believe when the faces are beautiful, and we can see Laura is beautiful in both pictures, but we're more seeing a lot of symmetry here, which is attractive. And why? Because that functions. This is effortless. It does not tax the nervous system. It doesn't tax the spine. And when we're drawing the line, we definitely can see the unevenness between the shoulders that are resolved. Ears and earrings in girls are really good pointer to show where the ears are. And here's Laura's posture in finished treatment. Some wouldn't even believe it's the same person, from the posture to the jawline to ear position to the nose, eye socket, and just about everything. And confidence. Like I said, beautiful faces function because they're not taxed. This is a person that actually is effortlessly going through life and is not paying a huge tax or finance for every breath and every movement they're making. So I wanted to show just some of the results, and we can get super critical about this, but this is mid-treatment. I don't have the final, I haven't had a chance to put together the final pictures of her occlusions, much better than this. But position of the mandible, overbite, and overjet, which has doubled over here in this picture, is directly showing where the occiput over the atlas is. When I see the vertical dimension or the Shimbashi measurements and overjet, I directly see where the atlas and occiput are in relationship to the spine. When you see the misaligned teeth, the crooked teeth, that is the position of the hip on both sides. This is a straight body and this is a crooked body. Straight teeth do not work on a crooked body. Mind you, there is no orthodontics done here. Body will erupt and put the teeth where they belong, and it will reverse engineer the damages. It has such an intelligence and it's such a sophisticated system to do it without any effort. And looking at the postures, position of the hands, we can see the thumbs, which postural specialists would jump over this because this is directly showing how the kyphotic neck position and caved in chest positions are, tightness of the pecs. Symmetry equals health, equals function. That's what we're attracted to it. Here's another young lady, similar treatment. These two pictures are even shorter period of time because as I develop my protocols, I become smarter and learn to decompensate the body in a way that doesn't allow it to revert back. And we all appreciate how much more symmetrical she is, effortless. And again, the skin tone, the position of the eyes, and the relaxation in the face. And these two pictures are only about 3 months apart. So I'd like to bring this up to finish some paradigm shift that I've adopted, and I would like to share with all of you guys. First, I never liked the word bite. To me, bite is a compensation. It's a dysfunctional state. I'd like to call where the positions that teeth come together as an occlusal suture. In essence, we have sutures in all of the skull and where the mandible and maxilla meet, which is the hard structure between the mandible and the skull, is the occlusal suture, interarch relationship, and I'd like to refer to it as a mandibular position. TMD, as we talked about, is not a symptom. It's not a symptom. It's not a syndrome by itself related to the teeth. In fact, it is craniocervical mandibular disorder. And dentists are cranial architects. We have full responsibility about where the teeth are coming in contact, where the position of the arches are, and all the skull bones and everything comes with it. And I'd like to share with you guys a couple of my favorite quotes here, that science cannot solve the ultimate mystery of nature. This is because, after all, we ourselves are part of the mystery that we're trying to solve. And we will never wonder why we never saw what was always before our eyes. The obvious truth is that the excess of technical and sectoral fragmentation in medicine has caused us to lose the sight of the whole person, in addition to the atrophy of our judgment and clinical diagnosis. Boy, isn't that true? And that's why, because knowledge is abundant, wisdom is not. And to bring this all to a finish, I'd like to share a video. Now that we talked about the landing, let's make sure we stick the landing.
Tied my church pants to my shelves. Should be easy. Can I even jump that high?
Hope you guys got a kick out of it. Not a chance.
My church pants to my shelves.
So with that said, I would love to conclude this presentation. Thank you all for your attention. And if you want to banter, if you have questions, here's my personal email. Let's bring on the questions, guys.
All right. Thank you so much, Dr. Esmaili. That was great. Still kind of chuckling from the last video. That was a fun way to end. We have a question that says, recently I had a patient who complained of mandible sliding to one side after going through Invisalign treatment with her orthodontist. Could it be a disc issue?
Absolutely. When mandible is shifting, and mandible has a status quo, pretty much where on a day-to-day basis, it's literally trying to bring the whole system together. When we move the teeth without checking on the cervical spines and mobilities and what's underneath of it, the teeth, in fact, movement of the teeth is what's communicating all of that to the brain. So I would definitely check with a chiropractor, and to be specific, I love sacrooccipital chiropractors. If you guys are interested, I will put in the chat box the website. You can check sourcey.com. Working with a chiropractor who knows how to align that will work. One warning: if you have finished the treatment, once they stabilize the cervical spine, usually the teeth don't land in the same place. So they might need some recalibration or perhaps alignment of the skull and addressing the occlusion as well.
Another question is, what was the appliance that Shaq had in his mouth?
So I believe this, for the purposes of this seminar, I would not be able to mention any brand names. So I would mention what appliance I did use, but it was a unilateral bite. And also I do use some light wires in his case. And like I said, I cannot mention names, otherwise you will not be able to get a CE for this course. I mentioned I don't have any affiliation. So I would, like I said, unilateral block system to address his asymmetry and continuing to develop the airway by light wires under positioning the bones.
Perfect. Thank you. Appreciate that.
And he's still actually currently in treatment. So doing great. And actually his hip surgery was not related to, it was not an accident, it was pre-planned. So he's doing really well with that too.
So after treatment, the knee and the gluteus muscles straighten also.
Well, here's the thing. When we move anything in the mouth, basically changing the interarch relationship, and what happens is the signaling to the brain changes. And a lot of times, if the mandible is moving in a favorable position, the signals of the teeth change. Decompression of the cervical spine will in fact cause decompression of the rest of the spine unless there's adhesions in the dura mater, which we didn't touch on today. I probably will bring that in a different webinar, but talking about dura mater, which connects the skull to the hip and to the tailbone. And when the tailbone position or sacrum changes, we'll position the hip in different positions and postures. And gluteus muscles, in counterbalancing effect with the inner thighs and adductors, work to position the hip. So yes, muscles and everything can change. But if the patient has ergonomic issues, on top of that, they have cranial issues, malocclusion, this is compounding effect. And I know a lot, when I was a personal trainer, I tried to do all of those glute activations and put the position of the hip in the correct place. And I kept seeing patients with the same malocclusion suffer from the same hip malalignment, lumbopelvic hip complex. They have a forward head posture, they have class 2 malocclusions, and they have a lordosis in their lumbar spine. And there was no way I could correct that, and it would revert back. This is how I knew this is an ascending and descending effect, and kind of opened that Pandora box for me. So if the question is to make the glutes work for you, I think you can, but if they have a descending problem, which majority of the time cause the problem for the hip, that needs to be concurrently addressed.
Thank you. And how important is your work with chiropractors or other specialists?
Super important. As a matter of fact, I don't think I have ever treated a patient for dental orthopedics without collaboration with chiropractors at the minimum. I work very closely with oral myofunctional therapists and a posturologist or physiotherapist that teach the patients how to use their rib cage in a correct syntax, obviously. Everyone has different compensation. To me, every patient has a different compensation they take. And what I really spend most of my time is diagnosing them to understand how to bring them back to health and homeostasis. So if an orthopedic problem is primarily a posture from a pelvis issue, that needs to be stabilized. And for all of us treating TMJ, I'm going to put this one out there. I have never seen a TMJ issue, TMJ, and I'm using air quote because it's really a whole body TMJ disorder, ever happen in isolation without a hip issue. Unless they can remember there was an accident, they had a concussion, somebody had blow in their head and displaced a disc. It is almost never a problem with the head. It's 100% of the time a side joint or sacroiliac joint issue, which basically takes the temporal bone or the TMJ hostage on that same side. It's body's way of saying, you know what, whatever is on the top, I'm just going to make sure that it doesn't fall forward. Remember the rule of 3B, balancing the head over the spine, and head follows the hip. So TMJ issue equals, for me, hip problem. I always dig into it, and there's different categories of that. Some people are way past the point of restorations of class 3 and are very minute. I'm glad to report it's 2% of population, majority are division 2 or a category 2, as they call it, which means the sacroiliac joint, which is bottom of the spine with the ilia, the 2 hip bones, are just damaged. The ligaments are damaged. There's no muscle guarding that joint. And kind of like TMJ, it's highly proprioceptive, no muscle going over that. So if the joint is coming undone, the brain is very well aware of it. So it would lock up the TMJ on the same side. Hopefully that makes sense.
What is the best way to find a chiropractic doctor who understands this discussion?
Well, hang tight, you guys. I think I will definitely bring my good friend and chiropractor, Dr. Craig Pearson, to one of the webinars, and he will shed some light into the most needed part. But in the meantime, I'm going to go ahead and in the chat box put in the website that you guys can go and look up for those chiropractors.
Awesome. Thank you.
Sourcec.com. Absolutely. This is where you can find chiropractors that are well trained in those techniques that you can work with. I would encourage you to go to their offices as they see your patients, collaborate with them in person. You can learn around from your chiropractors. Practically the last year and a half, 2 years, I've spent a lot of time learning from chiropractors, and it really brought that new perspective for me. And I know dentists will do much better if they have that partnership, close partnership with the chiropractors. But if this is of something of interest, Shailing, I promise I'll bring another webinar focusing just on the techniques of chiropractors and dentists together.
Perfect. Yes, we'll hold you to that one.
For sure.
You mentioned Steve Almost as a teacher. Were you also taught by Bob Walker? Much of what you say is in line with his teachings.
Yes, those are my great mentors. And Bob Walker is absolutely a gem. And much of what I know is he has taught me. And like I said, the best techniques that I have learned are from those that have looked beyond. So yes, Bob Walker is an amazing mentor of mine. I'm going to be seeing him again in 2 weeks and learning more about manual techniques. And there's never enough to learn. So yes, I do.
What percentage of time should the teeth be in contact? Then if the teeth are not in contact the majority of the time, do you see compensatory changes?
Great question. So the only in real time that teeth come together in contact physically is when we swallow, not chewing, because when we chew, there's food in between the teeth. Chewing is not an effect of the teeth. As a matter of fact, it's mortal and pestle. There's something in between the proprioception. When we swallow, mandible has a place that safely is suspended from the skull. And the purpose of it is to go home. I'm using the air quotes because where is home for the mandible? Because we have 2 temporal bones and 1 bone mandible that has to align itself with both of those 2 temporal bones. Now, if they're off in AP direction transfers or vertical dimension, lateral positions, the position of those temporal bones that are holding them will be affecting where the teeth are when we swallow. So tooth should not be in contact when we are not swallowing. Any outside contact, like bruxism, is in fact an indication that the system is in overwork and sympathetic overdrive. The bones that hold the teeth, the temporal bones, the entire skull is out of alignment. So one side of the skull is shifted forward, backwards, laterally, and it's always 100% of the time following the rest of the body. It's not in isolation. So teeth should not be contacting when we're not swallowing. And if we are, That's pathological, and the reasons usually are outside the mouth and are down the spine somewhere.
Do you follow syntax with your therapists?
You know, I try, and I use the word try because ideally, yes, but can every patient follow everything to the T? No, you do what you can for what they can afford and follow through. I work with a lot of patients remotely. I coach a lot of doctors remotely, and the best the patient can do to get to a SOT chiropractor is an hour drive. I work with a lot of patients. I have to come to Dr. Pearson that I work with, and they have to drive an hour and a half. So ideally, I would love to come in twice a week, which takes about 6 weeks to stabilize him. Can they do it? No, we do it the best we can. And in the meantime, I'd like to syntax my care with that patient so that when I intervene descending, meaning I insert something between their teeth, the body will not reject it. Meaning if I'm shifting the mandible and the skull to the right side that they've been avoiding, the hip is stable on that side. As I'm moving the cervical spinal fluid, the mandible, entire skull over that hip, the hip is not injured. That's my rule number one. And I don't ever deviate from that. So until they're stable enough, I don't encourage me doing anything in their mouth, because they kind of, like I said, that a person that was standing on the boogie board that was out of balance, that person is working really hard. And some patients are working even harder than others to maintain their balance. The minute we put something in their mouth and the chiropractor adjusts them, the body is trying to reestablish itself, descending, ascending, top to bottom, and constantly is reverting back. It's not progress, it's regress, and it's a moving target. So this is where I really like communications with my chiropractor, and oftentimes I show up in their office as they treat the patient, so we decide what's the best timing. It's not ideal for everyone, but I have personally completely deviated from clinical dentistry mainstream. So for me, syntax is ideal, but for most dentists do not have that. Just do your best to not do harm, and add this to your list of things to start communicating and working with some really good chiropractors you can establish relationship with, so that you can give the best care possible, humanly possible, to your patients.
How do you approach a patient when they need treatment from a chiropractor?
You know, this to me is actually a really good question, because we with the dentists, where we've been very much trained in isolations. We didn't even learn what occiput position to the atlas is in dental school. So it's not something that is foreign to most dentists to kind of talk to the patients. You need to go see a chiropractor, and why. But the more you're encouraging your patients to look into those other auxiliaries that, by the way, they're already going, it instills some level of trust in them, that not only you know what you're doing, but you also have their best interest in mind. Because a lot of times I'm not the first person to treat them, and I'm not in a hurry to stick in plastic in their mouth at any given point. I will do my best to insert whatever treatment modality in their mouth when it's the right time. So I see it as a positive rather than as a burden. To me, having a chiropractor that you trust and you've met, and you assure your patients that they will give you reports, it gives them that layer of confidence. And believe it or not, a lot of these TMD patients, that psyche really helps them. And in my experience treating over 200 patients with these protocols, I've had nothing but great experience. And by the time they're stabilized and come back to me, my treatments are very simple. And I get, I come out the other side smelling like roses. So be encouraged and do it. It's foreign to most dentists to say, well, that's where I start, or my functional therapist or physiotherapist at some point. It's not. I think it's making us a lot more collaborative, integrative, and in essence, the physiological integrated dentists that we should be treating TMD disorders.
Where can someone find all of this information, or how do they learn all the details?
That's a really broad question to answer. In the universe. Okay, I'm kidding.
Right, yeah.
That's a good place to go. Like I said, this was more of a coming out, and I want to tell everybody the broad perspective. I know all of the mentors you guys have mentioned have done that. I have one place I want to direct everyone if you're interested to learn more. Dr. Bob Walker, one of my most amazing mentors, exceptional dental courses. He is coming to the annual meeting in San Antonio, Texas. He's a great resource, guys. If you want to learn, that's where I would start. And I wish I had known him 4 years ago, but at the same time, I'm glad I learned everything else, because he made more sense to me having learned things that are outside. Remember, the facts were facts and opinions are opinions. He brought in more facts to my armamentarium than his opinions. although we are always biased about things we know. So that's a great resource. But also, if you are interested to learning more from this, again, he's an SOT chiropractor. Oral myofunctional therapists are a good resource if you're not familiar with that. Working with a myofunctional therapist and learning more about the function of the tongue oral space is a great place to go. Again, I don't sponsor any particular institution or modalities, but as a part of me being a part of educational committee at AACP, if this is of an interest, I'd love to know more about it as I'm getting involved with AACP. Our advanced courses are going to cover a lot of that. And one of my suggestions was to including this integrative part. So look out for those advanced courses that we're planning with Dr. Angie, and that would be included. So that would be also a good resource for you as a part of your AACP membership. And I think that's a great deal because we are all doing our best to bring the best of the knowledge and distilled to the facts and truth to make sure you're learning from the best of the best, setting the standard of care for you so you don't have to go years and years and spending thousands of dollars, like most of us did. So I hope I answered the question. It was pretty broad. I hope I was able to bring that home to you.
Yeah, fantastic. Well, we have lots of comments just thanking you and commenting on how wonderful your presentation was. So thank you again.
I really appreciate it. I want to encourage everyone again. My email, airwayarc@gmail.com. If you have any questions, if you need help with patient cases, if you just want to have a banter, email me. There's nothing that I adore more than just, communicating with other practitioners and like-minded dentists and empowering them and learning from them as well.
Thank you, Dr. Esmaili.
Thank you, everybody. Thank you so much for spending a part of your, Cynthia, so much. Thank you, Dr. Peterson. You've been one of my amazing mentors. I read your book, one of the first ones I read. You're amazing. Having a PT over here, my heart is just lightened up. So thank you so much for coming up.
Thank you. Have a good night, everyone.
You guys have a great night. Thank you, Shay.